Good afternoon. We're going to go ahead and get started with our session. We have 3 speakers today on our panel, and so I am going to give an introduction for all of them right now. So I'll just ask as I complete the introduction if the speaker will just kind of wave so we know who's presenting. And then I am going to allow our speakers to go ahead and get started. Each speaker will talk for about 10 to 12 minutes, and then we'll have time at the end for questions. So please do write them down so that you can ask those questions and won't forget by the time we get to the end of the session. So our first speaker, speaking on one key question in contraceptive deserts, Katherine Suellentrop is the Vice President of Programs with Power to Decide, the Campaign to Prevent Unplanned Pregnancy. She oversees programmatic efforts of the organization to ensure that all young people have the ability to determine when, if, and under what circumstances to get pregnant. She works with a team to support efforts in states and communities to ensure that young people have the information, access, and opportunity that they need to reach their goals, specifically related to pregnancy. This work includes community colleges, child welfare agencies, states and communities across the country. And her favorite part of the job is helping people connect the dots and try something new to ensure that people have the power to decide in their own communities. And then next up, we have Geoffray with the Women's Health and Family Planning Association of Texas, or WITHPAC. Cami joined the Women's Health and Planning Association of Texas in 2016 and has served as its Chief Executive Officer since January of 2017. Cami has a passion for improving the delivery of health and social services to vulnerable populations and has worked at nonprofit and government organizations, both at the state and national levels, most recently at the Texas Health and Human Services Commission. Cami received her Bachelor of Arts degree from Rice University and her Juris Doctor degree from Tulane Law School. And then last but not least, with the Texas Health and Human Services Commission, we have Viveca Martinez, who is the Deputy Associate Commissioner for Family and Social Services at the Texas Health and Human Services Commission. Viveca leads the teams who work with the Healthy Texas Women and Family Planning Program, and she has worked in state government for more than 10 years. Please join me in welcoming our panelists.
Great, thank you so much. We're just gonna pull up the presentation. I'm gonna tell you a little bit about our organization, and then we'll get into contraceptive deserts. So, Power to Decide, and I apologize if you can't see all the way on this slide, you can see on that slide and vice versa, and we're recording it. So we're an organization, we've been around for about 21 years. We believe that all young people should have the opportunity to pursue the future that they want. And we really focus on ensuring that young people have objective, evidence-based information about sexual health and contraception. We work to guarantee equitable access and information about the full range of reproductive health services. And so that's, I think, where one key question in contraceptive deserts come into play. And I'm going to talk a little bit about the data that we have and some of the solutions that we offer. And that we're also I live in Washington, D.C. We're a national nonprofit. And we really, throughout the course of our 2 decades of work, have been committed to finding common ground and common sense solutions. And we also try to catalyze innovation within the public and private sectors as well. And I'm happy to talk about any of that work afterwards. Come find me in the hallways. But in recent years, we've started focusing more on information access and opportunity. And when we think about those things, we're really looking at how can we set up an ecosystem and a system of support so that young people really feel that they have the information they need to make the decisions to support their future, that they have the access to health services to act upon those decisions, and that they have opportunity for their future, right? So addressing sexual health in a vacuum without thinking about future goals or schooling or that sort of thing is not as powerful as when we can partner with. That's why I love our work with community colleges, is if we can partner with community colleges that are already working on the opportunity angle, if we can partner with child welfare organizations that are working to help young people as they transition from adolescence to adulthood, to set goals around, independence, financial independence, that sort of thing, and ensure that reproductive health and well-being overall is integrated into that. I think that's when we can have the biggest impact. At least that's what we've seen. Today I'm specifically going to talk to you about our contraceptive desert work, which is essentially one of the things that, so how many people here have heard of Bedsider? Awesome. So bedsider.org is a comprehensive support network around around contraception. And the premier piece of it is a digital online tool. Most people can now come on a mobile device that provides information about the full range of contraceptive methods. Built within that, we also have a clinic locator. So let's say you're looking something up and you want to figure out if you can go get that method. And so the idea is you can look within the clinic locator and figure out where you need to go. And we have the most, if you can go to the next one, we have the most comprehensive clinic locator in the country. We get fed data from OPA, Planned Parenthood, and the HRSA, the Indian Health Services, NPIN, so lots of databases. And then we have a full-time person who just calls clinics all day, every day. And there's nothing like it in the country in terms of like a comprehensive suite of information around where you can get contraception. And we also demarcate if you can get the full range or just some of the methods. And we use access to IUD and the implant as our marker of full range, because it's in our experience that if you offer the IUD or the implant, you likely will offer the other services as well, like the pill, the patch, the ring, et cetera. And so we started to stay on the first one. We started to say, okay, let's look at the database that we have and figure out where we can see access to contraception and where there might be deserts. And I think we were talking this morning about stealing great ideas. We stole this from the sort of childhood obesity field around food deserts, because it's a term that really resonates. And we were looking at where are there contraceptive deserts in the United States. This map gives you, this map, the big map shows you, this is looking at the range of, to the full range of contraceptive methods. There's a couple things that are happening in this map. So the first is that we're looking at both sites where there are no access, and then we're looking at the level of access in sites with access. So just to break it down for you a little bit, anything to the left of the sort of like yellow in the middle is sites with no access. So increasingly orange or red is places where you have more women and there's no access. So there are several thousand counties that have no access to a single provider that provides the full rate. And this is in clinics. We don't, one of the limitations is we don't have private providers in here. So it's really like public clinics, and we're looking at women in need of publicly funded family planning. And then the blue is, so you would have some access, and the darker blue you have, the more access you have. So we describe we define a contraceptive desert as any place where there's less than 1,000 women per provider of the full range of methods. And so that's in the dark blue, and we base that on sort of the best, like recommendations, evidence-based recommendations of what adequate access might be. So this just gives you a sense of access to the full range of methods in the country. And if you go to the next slide, this is Texas. So there are approximately 1.7, I'm just gonna move this so I can see my notes, 1.7 million women in need of publicly funded contraception in Texas. And there are so this shows you access to any method, not the full range. And so you can see even there's gaps with that, which is not surprising. It's a pretty rural state. When you look at the regions where there are gaps, it's the more rural regions of the country. I was actually surprised that there are about 160 counties that don't have a single clinic that offers the full range of methods. And about 90 of these, so we're looking here, that don't offer a method at all, that don't have any contraception. So like we're talking about some serious gaps. If you go to the next slide, this is showing the full range of methods. So you can see in places with higher population that might not have a clinic. So there are definitely cases where there are clinics that don't offer the full range, and then there are gaps in service provision in general in the state, which I'm sure many of you are aware of. So this is the way that we have looked at the issue of addressing teen and unplanned pregnancy just from a different perspective. Like, where might people find access? We know that even having it in clinics is like one step along a long trajectory of how you go from getting there, getting the method you want, using the method consistently, et cetera. But it's just another data point. So now I'm going to talk about two potential solutions to how do we overcome this. And the first that I wanted to talk about is one key question, which is really a health transformation tool to try to better integrate reproductive and sexual health into a primary care experience. And also to work on breaking down silos across women's health, right? So how do we integrate, if you go to the next slide, how do we think about supporting a woman's decision around determining when, if, and under what circumstances to get pregnant, recognizing there's a lot of ambiguity around that. When I think about this, I think about my own circumstances. I have 3 kids, and for the third, I was like, I don't know, do we want to have another, do we not? We were definitely in an area of ambiguity, and I'm not sure providers are well positioned to hear that and then offer the support that clients need to help them think through that. So the idea is that we ask a introductory question and then take folks through an algorithm that provides them the support services they need, and the question is around, would you like to become pregnant in the next year? So women can answer yes, no, I don't know, I'm unsure, and they receive support services along the trajectory of those answers. So if they answer no, ensuring they have reproductive health services. If they answer yes, ensuring that they have a conversation around what does that mean, and when would timely entry into prenatal care, what does that mean for you, depending on sort of where you live, if you can have access to services. And then trying to just have a conversation about that ambiguity, because I don't think we have the answers around that yet. That's part of the challenge. I think there's no like clear counseling protocol to move people, but allowing them to think about that and what does that mean. And so the idea is to really integrate this into primary care and other safety net supports. And really, it's a patient-centered approach. I think one of the things that I was thinking about throughout this conference as we're thinking about health disparities, one key concept that we're using in one key question is how can we ensure all women are asked this question? So it's not just particular women are asked about their interests in when, if, and under what circumstances they want to get pregnant, but it's every woman who comes through the door as a way of trying to ensure that we're providing high quality care to women regardless of demographics, socioeconomics, et cetera. And we're not making assumptions about who should be getting pregnant, when they should be getting pregnant, that sort of thing. But we're really trying to transform this into a client's experience and help them think about it and support them instead of telling them what we want them to do. So we do offer a full day training on one key question, and a key component of that is really starting to dig into implicit bias and some of the sort of reproductive coercion, and how do we unpack that within our own practice, and how do we put in a protocol in place it doesn't have to be in a clinic such that everyone's asked the question and offered the support that they need. So I'll just leave it there. And for the next slide, I'm going to show you where we are. Some of you in the room might have received training. We did a training in Austin and have trained some folks in the state, which is really exciting. This is a map of just where we've provided training to folks. States like Hawaii and Connecticut are actually taking it statewide. Kansas is going to be taking it statewide this March, I think. And we're really looking at how do we expand this, and how do we do quality improvement on the training, and how do we offer one key question in a way that the folks who are implementing it are doing so with fidelity and get the support they need, as I said, to reduce disparities, et cetera. All right. And we are continuing to research. There's been a lot of pilot studies about one key question, and we've found high patient and provider acceptability of the question, as well as an increase in contraceptive counseling. We haven't seen quite the same change in preconception care. And so how do we ensure that we're really offering the solutions in a balanced way? I think contraception is just like an easier thing to measure than preconception health. So we're thinking through how do we do that. And then I want to offer a second solution. If you go to the next slide, this is something that we are also working on, and one key question kind of fits within, but looking at how do we, and actually Cammie was on our expert panel to help design this. We designed a better birth control framework. If you go to the next slide, it's really looking at how do we look at what is necessary to ensure that we're providing the full range of contraceptive options. So how do we close those deserts? In addition to integrating sexual and reproductive health services into primary care, how can we ensure that folks have what they need to offer the full range of methods, and that young people themselves have the information to pick a method that's right for them. And some of the strengths have been that we've developed an assessment tool, really helping communities determine where their gaps are, and then pursuing solutions to those gaps, and then a challenge with everything else is competing priorities in time. So I'm going to go ahead and wrap it up and turn it over to Cammie. Do you want to sit here?
No, I've got my slides. I'll just let you know in advance if that's okay.
That's perfect.
Awesome. Hi, everyone. My name is Cammie Geoffray. I am the CEO of the Women's Health and Family Planning Association of Texas. And I'm just going to give you a little bit about our organization before I kind of dive into the work that we do. So our organization was founded in 1977, essentially as a provider association, bringing together family planning providers to advocate for much needed funding in the state and to share best practices with each other. So it was really an organization of one person until 2013, when our organization competed for the Title X funding and received it for the state of Texas. So since that time, we've been administering the Title X grant statewide with a network of providers, and I'll tell you a little bit more about that shortly. But in addition to the work that we do around Title X to support our network, we also work to support other family planning providers. We provide training and technical assistance around a lot of the similar work, client-centered contraceptive counseling. Some of that involves one key question, other types of motivational interviewing, ensuring high quality of care, efficiency in practice, and just ensuring that we can meet the needs of women in Texas, of which there are 1.8 million women in need of publicly funded family planning services. So even though one funding stream will never be able to tackle that need, we do our best to help our provider network use the dollars that we administer. So we're more than a partner. We're more than just a funder. We try to partner and hear from our providers what they need to meet their needs of the community, and try to strategically place funds to meet those needs. So on to the next slide. For those of you who are not familiar with Title X, it's the only federal funding source that's solely dedicated to family planning services. So the priority populations for this grant include low-income, underinsured, and uninsured individuals that otherwise would not have access to care. In Texas, that has traditionally translated into undocumented populations that have no other access to health coverage. And although we don't get any information about people's status here in the country, we do have a high number of uninsured populations, which we know in Texas, without having expanded to Medicaid, most of those uninsured people are gonna lack status. There's also, I'm going to talk about some other key provisions around Title X, but one that's really important is that if someone needs the services confidentially, they can receive them. And that is really important in the context of minors accessing family planning services. So Texas state law requires that minors receive parental consent for contraceptive care. Because we have this layer of federal protection as a result of this funding stream, our providers are able to provide services confidentially to minors that need it. We certainly encourage folks to involve, parents and family members in those decisions and conversations, because we know that if you can have conversations about your family planning and your contraceptive method with important adults in your life, we know that you're having other important conversations that set you up for, a more successful trajectory. But that said, there is this protection. It's not limited to minors. It's for anyone who needs confidential services, women who are victims of sexual violence or intimate partner violence, spouses that don't want, the person who's carrying the insurance policy to know about their contraceptive coverage. But in Texas, it really is used to serve minors. So those are really our priority populations with the dollars that we serve are those undocumented folks as well as minors. So moving on to the next slide. our project currently includes 31 agencies that are diverse, as Texas is. So we're serving urban counties and rural counties through partners that include federally qualified health centers, health departments, hospital-based systems, university-based systems, and freestanding family planning clinics. We've got 120 service sites across the state right now. That's actually an increase of 30 service sites over the last funding period. So we've really tried to expand our footprint because, again, we know about the contraceptive deserts. You know, some of our clinics, you know, I think of Haven Health Clinic in Amarillo, where after funding cuts in 2011 went, you know, from I think 10 clinics down to 1 and is serving a service area of about 20 counties in the Panhandle. So, you know, we've seen access points really restricted. And we've had to think smartly about how we're going to provide these services and how we're going to support providers to provide these services. So we're really proud of what we've done with this project over the last 5.5 years. When we got the grant, we were seeing about 77,000 clients, and last year we saw 195,000 clients. So we've really worked to increase capacity, not only through adding service sites, but also through helping people think strategically about how they're delivering services in their site. Are they using, you know, their staff at the top of their license to deliver these services? Are they thinking strategically about their clinical protocols and their standing delegation orders? Are they offering contraception, you know, right away without requiring a physical exam? Are they getting people access to long-acting methods the same day? It also incorporates a lot of the contraceptive counseling, and one key question, you know, in that vein. So maybe someone doesn't need a contraceptive service, but we're talking to them about their reproductive life planning. And those visits are just as important when someone, you know, we absolutely know not everyone who walks in needs a method other than abstinence or condom use, barrier methods. Not everyone's going to want a hormonal method, but it is important to talk about what your goals are and what you want to do, you know, in the next year or two. So the annual report is there for more facts and figures at the door if you guys want to grab it. It's hot off the print press and smells lovely. So what kind of services are we talking about when we talk about Title X? You've got a couple up here. As I noted, reproductive life planning, which can include one key question, is one of those key services. We're also talking about pregnancy testing and options counseling with clients as well. Services to achieve pregnancy as well as prevent pregnancy, basic infertility services, STI treatment and services, including HIV/AIDS services. Many of our providers are offering PrEP. All of our providers are doing opt-out testing, which was a long path here in Texas and some more rural areas. Preconception health services, as well as a lot of related preventive health services. Over half of our network at this time provides primary care, either through FQHCs or through public health departments that are doing primary care. And so we are very much focused on integrating family planning into all service delivery lines. We know that if you're, you know, in an FQHC and you're being seen for an acute visit or, you know, you're doing that first visit, if we've got to refer you over to OB and GYN in order to get your visit, it's another barrier. So we've worked really hard to try to make sure that our providers are cross-trained on all of these issues and to try to eliminate the number of visits that clients have to come into, you know, and we know that those are roadblocks to accessing services. Many people drop out if they have to do one more visit. They can't get time off of work. They can't get the child care required. So we really do try to take that lens and help our providers think through how their protocols, which, you know, may be long-standing, may actually be setting up barriers to care in their communities. Okay, on the next slide, who are the clients we're talking about? For Title X, there's really no eligibility other than you need to be of reproductive age. So you need to become pregnant or cause a pregnancy, essentially. So there's no specific age limitation. And, you know, essentially you've got to get a family planning service. It could be pregnancy planning or pregnancy prevention. It could be that counseling visit around what you want to do. So, I mean, in summary, every client of reproductive age who receives a family planning service is a Title X client, regardless of who's paying for it, Medicaid, private insurance, or the client themselves based on the schedule of fees that we have in our clinics. But essentially, anyone under 100% of the federal poverty level receives services for free of charge. So on to the next slide, what are the benefits? That's one of them. So services for all clients, regardless of their residency or citizenship status, which I've touched on already, as well as their ability to pay. And as I've already touched on, confidential services for all clients, including adolescents if they need them. The ability to use the federal funding flexibly. So we really have worked with our providers to hear how best to maximize these funds and to provide overall support for their family planning services. Many people are providing family planning services already through Medicaid, Healthy Texas Women Family Planning Program, which Viveca is going to talk about shortly, or their federally qualified health centers that are getting Section 330 grants. And so we want to make sure that this is essentially a stretch fund and allows them to hire the clinical staff to deliver those services, to stock the supplies, including those long-acting supplies that have a high upfront cost, and to otherwise just use these dollars as they see fit to meet the needs in their communities. And then another big benefit of this program is that you get access to 340B drug pricing, which allows providers to purchase drugs at a discount price, including those long-acting methods like IUDs and implants. All right. I'm running out of time, and I think a lot of this will be covered in questions anyway, but there's a lot of federal action around changing Title X. And some of those things could impact Title X services in Texas. So it could impact the provider network as well as clients' ability to engage with that provider network. So I wanted to make sure that you guys had the background on Title X before we dove in. And we will definitely touch on this in questions. And we may come back to my slide next. So just so for your perspective, there was a funding opportunity announcement, then a set of proposed rules, then another funding opportunity announcement. And Kaiser Family Foundation put a great little slide together that has a whole timeline on this on the next slide. And so I know these slides will be available electronically, and I'm going to touch on some of this shortly. And we can definitely dig into detail during Q&A. But the reality is this administration is seeking to make changes to Title X nationally. In the last year, we've had to submit 2 competitive applications. The entire nation has had to compete for Title X twice, which is truly unprecedented. And there have been, an elevation of methods like natural family planning and abstinence, which of course are important methods, but are not selected by many of our clients. And so in the first funding announcement, there was a de-emphasis on those hormonal methods that came back into play in the funding opportunity announcement that was released this fall. But there is some concern that there's really a de-emphasis on hormonal methods, including long-acting methods, which we've really seen increase in Texas, which I'm sure Viveca will talk about, amongst the populations that HHSC funds, and nationally as well, as people are choosing those methods to help them plan birth spacing for longer periods and not have concerns about having to take a pill every day. Essentially, we're kind of in this limbo where we don't know what's going to happen in the direct impacts in Texas, but essentially if there's a change in who administers the Title X program, if it's no longer administered by our organization, but administered by another organization, that will drastically change the way that providers engage in this program, and some may choose not to engage in this program. As well as if there are change in programmatic rules, again, providers may choose not to engage, and clients may have impacts in their provider relationship that may make them choose not to seek services in these spaces. So I think that in a state like Texas where we have a huge access issue, placing more barriers in place of clients is just not the solution. But we're Texas, and we come up with our own solutions every day to try to make sure people get access to care. So no matter what they throw in our way, we're going to make sure we meet the clients where they are and support providers in doing the critical work that they're doing here in Texas. So with that, I'm going to pass it over to Viveca.
Thank you very much. It's always a pleasure to be on a panel or just to be around these ladies. There's always something new to learn. Before I step into my presentation, I actually took a quick head count, and we have roughly 60 people in here. And I'd like to know how many of y'all know about the Healthy Texas Women Program. By a show of hands. That is wonderful. That definitely helps us to sort of step up what we want to discuss about the programs that are offered by the state. And so I'm here representing the Health and Human Services Commission. And basically in my shop, we have 3 programs that are outside of Medicaid. Those are the Healthy Texas Women Program, the Family Planning Program, and the Breast and Cervical Cancer Services Program. And I think when we were preparing for this speech today, you know, whenever we come out to these conferences and these events, we really look to y'all to be our strongest advocates for ensuring that the public has a good working knowledge of these programs and the availability of the programs. Also, so that you can talk to your friends and your colleagues and other individuals, not just the clients, but professionals who are looking to expand the programs that are available in their clinics. And so that's really incredibly important to us that y'all are able to take that information back. In case you didn't see, downstairs there is a pink table, and on that pink table you will find information, flyers, and Charlene is usually down there. She can answer any questions that you have about the programs. And so we've got these 3 programs here at the state, and Healthy Texas Women is actually the most comprehensive of the package that we have. With Healthy Texas Women, what we'd really like to make sure that a lot of the folks at this conference understand is that women who are on Medicaid for pregnant women, when they roll off roughly 2 months after they are coming off of that particular program, they can automatically enroll into the Healthy Texas Women program. There's a lot of folks that we're still trying to educate to that because they're not necessarily knowing that that occurs. And for us, it's incredibly important for someone to know, as you know, they're having their children and they're caught up with everything else that's going on. We'd like to be able to message to them that they are on that program if they're found eligible. And that's incredibly important. In terms of the work that we're doing at the state, I think, you know, we are really focused on trying to ensure that we improve access to healthcare as much as we possibly can. And what that means for us is, you know, Cammie and Katherine, they touch on it. There's always going to be a need, and the need is always going to be greater than one program can possibly, you know, meet. But together, when we continue to have a presence at these conferences and at different conferences and become more educated about what's out there, the more that we can really funnel folks toward programs that they're eligible for to find the services that maximize their potential. With these programs, individuals, if I can talk just a little bit about enrollment in these programs. So for the Healthy Texas Women program, as most of you raised your hand, you probably know that at any point in time, you can elect to be a provider under the Healthy Texas Women program, you know, meeting certain requirements. With the Family Planning Program and the BCCS program, those are both programs that individuals or organizations and clinics, hospitals, et cetera, have responded to a procurement that was published from the Health and Human Services Commission. In response to that procurement, entities were awarded levels of funding that they now use in order to administer those programs. We were really fortunate that all 3 programs procured at roughly the same time. And what that ended up doing is a lot of providers actually responded to all 3 of the procurements because Healthy Texas Women also has a procurement component to it. And so these individuals, entities that had all 3 responses, they may have gotten contracts to perform under every one of the programs. And so what we do with folks who were able to obtain that is we talk about maximizing your dollar, maximizing your funding. And so we spend a lot of time going into different smaller groups, you know, groups of 10 to 20 folks to really talk about what it means to finance healthcare with these programs. Understanding that a lot of these folks also have access to other funding streams and helping them to really wrap their minds around and expand their knowledge of how do I funnel someone toward one program and another so that I can maximize the amount of people that I can serve. So I think, you know, it's important for me to say that to everyone in this room because sometimes when we come in for certain conferences, people can sometimes have an idea of what the state can do or should do or is able to do. And I like to step us back and really talk about what we have available to us. And one of those critical pieces is being able to educate folks as to how to improve the business model so that they can do the most with all of the other things that they may have. Recognizing that at the same time, there's always feedback that comes to us about where the gaps are still there. What else needs to be done in public health in order to meet those gaps? And, you know, we're not always able to answer every one of those particular needs, but in partnerships like this, we're able to get to better places. So, you know, I take that back to the beginning. There's roughly 60 people in this room. If when you walk out of this room, you talk to just 5 other people about these 3 programs, you've just informed 300 people about the existence of these 3 programs. And we would encourage that in that conversation, maybe they come back and they can talk to you about 2 other programs. So really, that's how we really look to form the partnerships across the table and across everybody in the room in order to maximize that care. In terms of the performance under the programs, we've seen upward trends of the amount of clients served. We have data that was released representing our first year of the launch of the programs with almost 200,000 women served. That's incredible for us, especially knowing that, you know, these programs are now entering their 3rd year, and we are monitoring constantly, not just for the amount of clients that have been served, but how can we further improve the delivery of these services. And when I say improvement, I encourage individuals that we talk to really be open and honest with us as to what they're seeing in their clinics, in their hospitals, in their delivery systems, because we at the state, we take all of that information in. We really do. You know, the folks that we've got back at HHSC headquarters that are working on these programs, we spend a lot of time every day reminding ourselves that while we are extremely passionate about what's going on, and there's a lot of folks on the staff that are very knowledgeable, it's actually you that are on the ground that really knows what it means when the rubber hits the road. And if we're not coming out here and having a presence and really listening to y'all, and that means the good, the bad, the ugly, every angle of it, then we're not able to really take back home what's the really strong information to help us to continue, improve, and reform, and get to where we need to be to address the gaps that these ladies have just indicated still exist, you know, across the state and across the nation. So, you know, with that, I would encourage y'all to spend some time going downstairs to the table, spend some time, you know, talking to us. I'm looking forward to the Q&A more than anything, and looking forward to hearing from y'all, even those things that are difficult to digest, so that we can make sure that we continue to improve delivery. Do you want this back?
So we have 1 mic, which means we're going to get our steps in today. So anyone who has questions, we'll kind of put the mic kind of here. And so if you'll come up, just in case if there's, I don't want to have to cross over and step on anyone.
This question is for Cammie. So there's been a lot of talk, especially you know, in the Trump era, and I live in D.C. also, so there's just a lot of buzz all the time about Title X and discussions about abortion, or, you know, offering or referring for abortion services, and that if that happens, that you could lose funding. Could you talk about that, where we are with that?
Am I going to respond or take Evelyn's too?
Hi. So one of the things that I mentioned was a notice of proposed rulemaking that came out in early 2018. And that was widely referred to as the domestic gag rule, which basically said any provider that takes Title X funding cannot speak about abortion unless a client specifically asks about it. And then at that time, the provider would provide a list that may or may not include an abortion provider on that list, and they could not in any way indicate to the client that an abortion provider is on that list, and that is the particular provider that they need to call. So, or call everyone or guess. We have not seen the final rule, so that was a proposed rule. We were expecting the final rule around the end of the year or sometime in January. Although the agency was completely funded during the shutdown, a lot of things impacted Office of Management and Budget, where rules have to go through. So a lot of things did slow from that perspective. So although we were expecting it in December or January, we're not really sure when we're going to see it now. So we don't, as a lawyer, I never want to respond until I see the actual text. So until I see the final rule, I'm not really sure how we would implement that. But essentially, whenever the rule becomes final, we have 60 days to implement that, unless it will be postponed as a result of a legal challenge, of which we expect to see many across the country. But what we know about the domestic gag rule is that it's going to put a barrier in place of people seeking services, including abortion services, which are legal, and which are not funded by Title X dollars. There should not be a concern that the mere mention of abortion or pregnancy termination when you're conducting options counseling could result in the removal of your funding. And my biggest concern is that for a client who needs to make a decision about their pregnancy when they have a positive pregnancy test and they see their Title X clinic as a safe space to have those conversations with those providers, they will no longer see that as a safe space and they will disengage from healthcare. I'm also concerned that providers will feel like that is an intrusion upon their provider-client relationship, and they may decide for themselves that they don't want to participate in the Title X program at the moment when we need more providers, not less.
Thank you, Cammie.
This question's for Viveca. Thanks for having the programs for women's health. We really appreciate having that, those services available. For the coming biennium, when the budgets don't look like they're really skyrocketing for women's health, but we know that there are more women in need, and we know that average cost per client served could go up because of LARCs. They're more expensive, more effective, but more expensive. Does that mean we'll likely be serving fewer women because the budget doesn't really increase unless something else happens? How will y'all be addressing that?
Well, that's a really good point, and it's always dependent on funding, right? I think in general expenses always go up, things are always increasing in cost. So it's the start of the session. We're definitely monitoring what's going on down at the Capitol. Obviously, we hope that we ensure that we have level funding. Hopefully, we'll have increased funding. It's just dependent on what results there. So we're monitoring. We'll do the best we can to educate folks. I know there's a lot of folks in this room that are also doing a good job of educating the legislature on what those dynamics are. And, we're just thankful for the support. But great question, Evelyn.
And you may have already answered this question. I don't think so, but so when my patient is, I work in a small hospital, primarily Medicaid and or self-pay, and when their Medicaid runs out, or they miss their postpartum appointment, and whatever, is there a phone number that I can give them or a website to see how they get y'all's funding? You said that when their Medicaid runs out, they can get your funding. What's the best thing that I need to give my patients in Jacksonville, Texas? So I looked up on your website, and there's one public provider. It's not through our hospital. I don't know if they're going to want us to, it's the competing hospital clinic. So Family Circle of Care, yes. And well, it would be private physician. I don't know. Well, yeah. Okay.
I was going to say we can get you the materials downstairs, and it'll connect you to a website. We can also connect you with myself and Charlena, so we can get your information. If for anyone who wants to kind of see who might be an available provider in their area, they can go to healthytexaswomen.org, and it might show you who to refer to. Tyler Circle of Care is one of our providers, so we definitely have someone near you. But we'd love to connect with you and anyone else so we can kind of take a look at your area, see what's available for you, walk you through the steps of accessing the online provider lookup, and see what we can do for you.
And so from our perspective, we've got a network of providers. We also have a clinic locator on our website, but we do feed to the bedsider clinic locator and Power to Decide hosts as well. I think for many clients, they will auto-enroll from Medicaid into Healthy Texas Women. Some clients will not. And so that's why it's important to kind of think of all of the access points in your community, whether it's a Healthy Texas Women provider, a family planning provider, or a Title X service provider. But Tyler Family Circle of Care is in our network and also provides care through Healthy Texas Women, and hopefully in the future family planning program once again.
Program? Okay.
And just one thing, if you are interested in expanding access within your own setting, you can look at the Better Birth Control framework and look some of the common barriers we hear. If you have a high population of self-insured, we hear that providers say, well, I'm going to lose money offering IUDs and implants. And there are some tools that you can go through to actually assess if that's true. You know, it's really challenging to figure out where you're losing money in the healthcare delivery system, but there are some tools, there's some great resources within that framework that will help you understand if in fact you are, and in many cases, those are covered at a pretty good reimbursement.
Thank you, all of you, for your presentations. So I have a couple of different questions. One is, and I'm about to give the next lecture downstairs about LARCs, immediately postpartum LARCs. So one of my questions is, in working as a physician champion for other hospitals and to get inpatient, immediate postpartum LARCs, is obviously the barrier of cost. And so, Cami, when you were speaking, I guess one of my question is because Title X is for any women, regardless of their socioeconomic status, high or low, would your organization be able to help these hospitals with getting like these initial sets of LARCs up front, and then when they get reimbursed by whatever programs the patients are using, then they can replenish it themselves?
So what we heard from providers when we started this project in 2013 is that as a result of the drastic changes to the programs in 2011 and 2013 at the state level, they had to cut costs. And one of the first things they cut was long-acting contraception, because IUDs and implants are costly even if you have that 340B drug pricing. So we heard that, and we took it back and we tried to think, how are we going to make this work for them? And we actually dedicated a portion of our Title X funding to create a LARC fund. And so that helps clinicians talk to their administrators and say, hey, I know you think these devices are costly, but our funder's telling us to prioritize them. And so we have this dedicated funding stream for this carved out of our other Title X money. At the time, Obama administration was prioritizing access to long-acting reversible contraception. We could really lean on that. We're still doing a lot of work around contraceptive access. So our providers get we have an allocation methodology, and they get a dollar amount, and they get an upfront, and they stock their shelves, and then they worry about the cost on the back end. Many of the clients are going to be below 100% of the federal poverty level and never pay a dime for that device, and that's fine. Many clients are covered by Medicaid or HTW or family planning or commercial insurance, or they're on the sliding fee scale, and they can recoup some of that and put it back into their program. So that's something that we do. There's a stakeholder group working on novel ideas with the state and their funding around how we can start doing some LARC purchasing. There's also a lot of private foundations that are doing work, including the St. David's Foundation, that's actually funding our organization to model a LARC fund in Central Texas. So it's something that we hear from the provider community, we acknowledge, and for a lot of those hospitals that can't use their 340B inpatient, it can be challenging. And so we encourage people to talk to us. We're always looking to grow our network with the dollars that we have. And we're trying to strategically place those dollars to make sure that people can get 340B drug pricing. The inpatient is still sticky, and we haven't solved it. And I've been working on it since 2013. But I think we're getting there.
My follow-up question for you is, in looking at Healthy Texas Women, at the family planning programs through the state, if you read the fine print, there's a gag rule there too. And so it limits the number of providers who are interested in even signing up to be providers, because it specifically states that we cannot discuss abortion. And so I'm just curious as to your thoughts on if there's any movement there as well, because it's one thing to be able to, don't get me wrong, I applaud the fact that we're rolling people over into Healthy Texas Women, but if there's only one provider in the state for them, it's still going to be difficult to get them access.
Yeah, so we've been really fortunate to have almost 6,000 providers who have enrolled in the last. Yeah, yeah, no, but I appreciate it. You know, as always, the design of the programs is really determined by the legislature and what it has asked us to do. And so for the time being, you know, that is definitely something that we're still under. So.
Hi, thank you all for your presentation. Ms. Martinez, this question is for you. For BCCS, like if a patient comes and they're diagnosed with, say, cervical cancer, breast cancer, what are their next options after that?
So our team actually works on the applications and reviews and then refers those to the MBCC, Medicaid for Breast and Cervical Cancer Services. Otherwise, we're also working with different stakeholders across Texas so that if for any reason they're not eligible for that particular program, we try to connect them to alternate options. Yeah. So her question is regarding services that might be covered under MBCC, so Medicaid for Breast and Cervical Cancer Services. And actually, I would need to rely on my partners in that program to really specify everything that's eligible under that program. I don't think that those folks are here today, but if we can connect later, I can definitely help you with some of that.
Other questions? Well, I have one for the panel. So each of you kind of mentioned different barriers that come up in terms of women being able to access contraceptive deserts. We have the new changes that might be coming down the pike for Title X. I know in several communities, as far as Healthy Texas Women and the Family Planning Program, they actually ran out of funding halfway through the year this past year. We know, as it relates to the different contraceptive deserts, that there's going to be barriers. This being a community health session panel, we aren't the ones that are creating the barriers that exist. We aren't the ones that are coming up with the pay codes or doing any of that. So in this type of session with these type of practitioners, what is the role of community health and basically being able to reduce some of those barriers? Like, what are you see as the people in this room of being a change agent to help with some of the things that have come up during this session?
I think, and I can speak from the national perspective, I think your voice is incredibly important and valued in continuing to underscore the importance that family planning really has to play in the broader maternal and child health and women's health overall. We have unfortunately, in the last 40 years, really separated out family planning as a unique specialty service that women now have to jump through all sorts of hoops to try to get, when it's really just a part of basic health care. And why should we carve it out? How can we ensure that women have, if we take a client-centered perspective, that they're getting the services they need when they need them at the point without having to go to several different doctors? And I think helping to raise those issues and remind people that if we care about healthy mothers and babies, we also need to make sure that we're caring for the full. That's why I loved the goal of women's health across the lifespan. That includes ensuring that they can determine when, if, and under what circumstances to get pregnant and have a child, and figure that out for themselves. And it shouldn't be determined for them or a result of the circumstances that they find themselves in.
In our project, we incorporate a lot of CHWs and promotores to do outreach and education services. And as I mentioned, for us, a family planning service also includes those reproductive life planning conversations. We know that a lot of our clients don't want to engage in the clinical space oftentimes immediately. They've encountered bias in those spaces. They have fears of leaving their communities under the current administration if they're concerned about their status. So we've really worked to make sure that we're meeting people where they live and work in their communities. We're working through how we can start using some of the more opened up telemedicine and telehealth legislation that happened last session. And again, we're really just trying to figure out how to go out using mobile units, using some sort of technology, and again, leveraging those CHWs and promotoras to have those critical conversations and support people to come into the clinics if they do need clinical care, but also help people plan for their pregnancies or, choosing not to be pregnant, out in the communities doing what they can with their limited supplies. I mean, we go to churches, schools, jails, we go to, drug treatment centers. Many of our providers carry like a tackle box of materials and go out and do that work because they know that people feel safe in those spaces and they feel seen and heard in those spaces.
So real quickly, to echo what they said, I agree. And also I would add that the greatest tool to removing barriers is education and community. Education and community. In order to know that the barriers exist, you have to be willing to talk about them. You know, we represent the state, so there's certain limitations on what we represent, but we're listening. We do listen, and where we can make changes, we try to make those improvements. But the barriers, education, and community. These three, just real quickly, these three programs that we talk about, breast and cervical, family planning, and HTW, are only 3 programs that house in the department in which I'm over. The other programs really are helping us to move an initiative that we call personal responsibility. And that's essentially being able to communicate. We are able to communicate with individuals from the ages of 10 to upwards of 64 through all the programs that are housed in my department, which I'm happy to share in another on the side note. But because we have that, we have a unique opportunity in our department to really think about what it means to grab someone who's young and think about what kind of choices and personal responsibility aspects they're thinking about for their life as they're moving on the continuum of life. So, so to remove the barriers, it's education and community.
And I think we're at about 3 minutes, and so we'll have to take 2 more questions.
Okay, so my quick question was, again, on the budget, Viveca. Okay, so we have family planning and Healthy Texas Women in the same budget. And so as you see an increase, it looks like there continues to be an increase in demand for the family planning program. And will you be intending to make adjustments to that family planning budget to increase it and take it from wherever the other 2 programs are to meet that trend? Is that the intent of having them under the same budget? And are there plans to do that?
So I'm not completely clear on the full intent of the legislature for streamlining all of them, but I know that from a program perspective, it's made it a lot easier for us to really understand how the funds work together and how the programs can work together and kind of strategize for the individuals who are leveraging the funds. So we're definitely closely monitoring, and like I said, removals to barrier, education, and community, you are our community. So the more that you're out there educating the individuals who have a role to play in what happens with these programs, including and especially the funding of those programs, we encourage you to have those conversations.
Okay, really quickly. Oh my gosh, this is what I sound like. So with my specific program and just with my just professional life, sometimes I work with moms that know eventually that they want to do that, but maybe not after the 60 days are up. So I'm wondering, as long as they express interest in it, but maybe not choose a contraceptive method, are they still included under any of y'all's programs? Or is it once they actually commit to one? Because I was also someone who didn't agree with a lot of contraceptive methods, so it took time, and I wanted to take breaks between those because you don't want to just go from one to the next to the next. And so that was really like my main question for me.
Yeah, our clinics serve anyone that is of childbearing age, so you can come in. It's not a coverage program. Anyone who walks in our doors can get services on a sliding fee scale, and if you're below 100% of the federal poverty level, they're free. Again, many of our providers, service providers in Viveca's program, so she'll talk about the ones that people can access depending on where they fall.
Mm-hmm. So it's really dependent on what it is that you're wanting for the service. And so as long as you can access one of the providers, it's a conversation you can have with the provider as to when and which contraceptive you actually would like to utilize.
So does this also include the removal? And okay, because we already know that there are a lot of barriers even just to removal of the IUDs. So in asking that question, would that include those barriers as well?
Whenever we're talking about LARC, we're always talking about insertion and removal. We've got a training coming up in a couple of weeks here that will have insertion and removal and difficult removal training as well for our clinicians.
That is our time. Thank you so much. We're joining back in the general session room by 3 o'clock. So 9 minutes.
Across the room.